I'd like to thank the organizers for giving me the opportunity to discuss abstracts 4, 5, 6, and 7 today. I have no disclosures. In the first two abstracts, we heard about hormone-positive early-stage breast cancer in premenopausal women, evaluating the role of ovarian suppression with tamoxifen or aromatase inhibitors. First, we heard of a meta-analysis of 7,000 women in 4 randomized trials presented by Bradley and colleagues. And secondly, updates from the soft and text studies. As all of us know, and we heard earlier today, tamoxifen reduces the 15-year breast cancer mortality by approximately 1/3 in hormone-positive breast cancer. Aromatase inhibitors are even more effective than tamoxifen in postmenopausal women, raising the question, what is the role of ovarian suppression and/or aromatase inhibitors in women with premenopausal breast cancer? Within the first study, we heard about a meta-analysis performed of approximately 7,000 women after a median follow-up of 8 years. Within these 4 different trials, there were different choices of ovarian suppression. 2 of the studies used zoledronic acid, and the choice of aromatase inhibitor differed between the different studies. Overall, there was a 21% improvement in recurrence with the use of ovarian suppression and an aromatase inhibitor over tamoxifen alone. This did not, however, translate into an improvement in breast cancer mortality, and within these analyses, recurrence was defined as distant recurrence, contralateral recurrence, or new breast cancer. From the soft and text studies previously at 5 and 8 years median follow-up, we're aware that the addition of ovarian suppression to tamoxifen reduced recurrence and death. Further reduction of distant recurrence, but not death, with an aromatase inhibitor and ovarian suppression versus tamoxifen and an ovarian suppression. But the absolute benefit varied depending on the underlying risk of recurrence. And those with lower risk clinical pathologic features fared well with tamoxifen alone. Today, we heard about a planned updated analysis with a focus on distant recurrence and overall survival after a median of 12 and 13 years. For those women who were treated with no chemotherapy, more than 95% of women were surviving at 12 years. Within this group, there was no difference between those who received tamoxifen and tamoxifen plus ovarian suppression. There was a slight increase from 95.8% to 97.1% in overall survival with the use of an aromatase inhibitor with ovarian suppression over tamoxifen alone. In combining the analyses from the soft and text studies, there were slight improvements with the use of ovarian suppression with an aromatase inhibitor compared to ovarian suppression with a tamoxifen. It's important to note in these trials that the use of chemotherapy was up to the decision of the primary treating provider. For those who received chemotherapy, however, there was an absolute reduction in distant recurrence of approximately 2.6% at 12 years, with reduction to death that persisted and an absolute reduction of 4.5% at 12 years in looking at tamoxifen versus tamoxifen plus ovarian suppression. This also resulted in reductions of 4.5% and 4% at 12 years in those who received ovarian suppression plus an aromatase inhibitor compared to tamoxifen. In combining the soft and text studies looking at the 2 different ovarian suppression regimens of tamoxifen versus an aromatase inhibitor, there were no differences in overall survival with the soft study and 2.6% with the text trials at 12 years. In looking at subgroup analyses, this benefit was largest in those that were under the age of 35 and in those who received neoadjuvant chemotherapy. There was an approximate 10% improvement in those who received tamoxifen plus ovarian suppression compared to tamoxifen alone in this youngest age bracket, as well as a 15% improvement in those who received ovarian suppression with an aromatase inhibitor compared to tamoxifen alone at 12 years. So in looking at these 2 trials, in hormone-positive breast cancer, premenopausal women not requiring chemotherapy do very well, with over 95% having survival at 12 years. Ovarian suppression plus an aromatase inhibitor continued to be superior to tamoxifen in preventing recurrence and in overall survival, with the magnitude being largest in those very young, less than 35 years, who also received chemotherapy. Questions still remain in looking at these trials, however, and putting them into clinical context. For those who receive chemotherapy, particularly neoadjuvant chemotherapy, and have an excellent response and achieve a PCR, is it actually necessary to recommend ovarian suppression with an aromatase inhibitor? Secondly, what is the optimal duration of endocrine therapy? In these trials, endocrine therapy was used for approximately 5 years. We know from other studies, such as the Atlas and Adam trial and NA17, that there are improvements in outcomes with prolonged endocrine therapy. And with the recent approval of abemaciclib in the adjuvant setting, how does abemaciclib fit into this equation? It's also important to think about survivor considerations. For those who were treated with aromatase inhibitors, there was increased fractures of approximately 5% compared to 3.5%. Many of these young patients are also inquiring about improvements or changes in quality of life, as well as future fertility. We know from other studies, there's questions about compliance. And finally, based on other cohort studies, such as this one from Olmsted County, what about future cardiovascular risk? Women who had oophorectomies less than the age of 45 years versus controls had an increased cardiovascular mortality with a hazard ratio of 1.44 within this cohort study, raising the question about future cardiac risk in our individuals who are receiving ovarian suppression. In the next two abstracts, we looked at the role of chemotherapy in early stage breast cancer. First, with a meta-analysis of 16,000 patients with early stage breast cancer in 13 randomized trials. And secondly, we heard about updates from the RxPonder from Dr. Kevin Kalinsky. In looking at the RxPonder data, we know that women who have lymph node positive, 1 through 3 lymph nodes, hormone positive, HER2 negative breast cancer have no improvements in distant relapse-free survival for those who received chemotherapy versus endocrine therapy alone. This was seen primarily in postmenopausal patients where the use of chemotherapy in those with a recurrence score of 11 to 25 had no improvements in outcome. So what about in premenopausal patients? Within the updates that we heard today, there was a 5-year disease recurrence-free interval absolute chemotherapy benefit of approximately 2.4% in premenopausal patients. This was seen in both those with micrometastatic disease involving the lymph nodes and in those with N1 disease. For those with N1 disease, the 5-year invasive disease-free survival absolute chemotherapy benefit was approximately 4.8%, arguing that many of these premenopausal women do benefit from chemotherapy with a recurrence score of 11 to 25 and 1 through 3 lymph node positive. Within the study analysis, we heard, however, that the benefit was seen in women in both arms of the study if they had suppressed menstrual periods. In those who achieved or were treated with endocrine treatment alone, there was an improved invasive disease-free survival if no regular periods occurred within the first 24 months. This was also seen in those who received chemotherapy with endocrine treatment, raising the question, is the benefit from chemotherapy actually from ovarian suppression, or is it from the chemotherapy itself? And this question still remains. We then heard from the Breast Cancer Trialist Collaborative Group about a meta-analysis of 16,000 participants from 13 randomized trials before 2010. Within these analyses, we heard about several different courses of taxane-based therapy with and without anthracyclines. The primary outcome was time to invasive breast cancer recurrence and breast cancer mortality. In looking at all of these studies together, there was an approximately 15% improvement in recurrence with the use of anthracyclines over taxanes alone. This, however, did not translate into significant improvements in breast cancer mortality. In looking specifically at the regimens using taxanes concurrently with anthracyclines, the largest benefit was seen, as opposed to those who received sequential treatment. This was seen across those with both hormone positive and hormone negative disease, as well as lymph node status. So how do we put all of this together? Many women with early stage hormone positive breast cancer will do very well and may require only tamoxifen. Using genomic platforms to stratify the role of chemotherapy, premenopausal women with recurrence scores of 11 to 25 with node positive disease may benefit from chemotherapy, though further work should explore ovarian suppression as a therapeutic option over chemotherapy. And for those high-risk patients who do need chemotherapy, the addition of a taxane to anthracycline provides approximately an additional 15% risk reduction in recurrence. For those who do receive chemotherapy, ovarian suppression plus an aromatase inhibitor provide the most protection against recurrence and overall survival. And today, questions still remain in the current environment how to incorporate excellent responses such as pathologic complete response into decisions about optimal choice and duration of endocrine therapy. Finally, it's important to weigh aspects of survivorship, cardiovascular risk, fertility, bone health, quality of life into these discussions with patients, as this component is essential. I'd like to thank the organizers for allowing me this opportunity to speak today, as well as my colleagues at the Masonic Cancer Center for providing feedback on this talk today. Thank you.